All right, we're live. Everyone is in the session. I'd like to welcome you. You're in the Rubschlager building goes on a controlled pause presentation. This was submitted by Mike Doyle, Senior Vice President of HDR. My name is Adam Kaisers. I'm a program manager with Jacobs, and I'm actually filling in for Mike today. He had something pop up. So welcome. We have a great session for you. Just a quick intro of 30 minutes, the presentation, and then we have 15 minutes allotted for Q&A. We'll try to make it all the way through that. We have two panelists today, originally scheduled for three. Ray LeBrecq is the AVP of Facilities Management for Rush University Medical Center. Dr. Tony Perry, VP of Ambulatory Transformation for Rush University Medical Center. And then Patty Nedved, AVP of Ambulatory Transformation with Rush as well, had something come up. So I'll do a quick little intro, and we'll get right into the presentation. First is Ray LeBrecq. He's a licensed architect. He's the Associate Vice President, as I mentioned, of Facilities Management here at Rush University Medical Center. And he oversees all of capital projects and corporate real estate at Rush. Ray was also the Deputy Director for the multi-award-winning Tower Hospital building transformation project on Rush's campus, which we could touch on very long and esteemed program here. Tony Perry was also a key member of the Tower's transition team as well. Tony is a geriatric medicine physician here at Rush University Medical Center. He's also VP of Ambulatory Transformation at Rush. He's also the recent recipient of a Healthcare Design Magazine HCD 10 Clinician Award for 2019. So congratulations with that. And without further ado, we're going to dig right into it. We've got a great presentation here for you. The question number one to Dr. Perry, and then we'll move to Ray and get through our questions here. This is an interesting session title. Could you explain the concept behind a controlled pause? What were the parameters, the considerations, and how did you implement this controlled pause?
I'll start with that, Adam. Thanks very much for that intro. The concept of the controlled pause was a very contextual one for us and sort of derived internally through the processes we were going through in the very early days of the pandemic. And it made sense in the context of kind of what we were going through there. We had a variety of inputs that we were sort of tracking at that point in time, and actually very early created a risk register for ourselves that tried to look at external elements that were affecting our project. And the risk register very early on, which was for us in the February and March timeline of last year, included things like authorities with jurisdiction over our project. For example, we had conversations going on that included the fact that the governor was deciding on what to shut down and what not to shut down, and construction work was part of that conversation. We had people as part of our risk register in there that was all about how can we keep people safe and how can we do work safely, and asking the question of were we going to get to a point where we thought we could not keep the work going in a safe fashion. Ray was really looking at supply chain risk as a topic for us and looking at all the supplies we're getting from in different spots, and are there any supply chains that are going to become issues for us, or are there going to be any production issues that will hit us? And then actually, it wasn't even in our first risk register, but what really became increasingly apparent in the early days of this was that cash flow was a real risk for us. Again, it wasn't on our initial risk register, but it was pretty clear several weeks into this that the impact on our operations was profound. And then sort of cash flow became this very large thing and became a dominant risk component for us. And in the context of that, as you could guess, we were managing with our executive leadership and our board there, and we had to craft a whole set of scenarios that got us through that. And as we were crafting scenarios about how we would anticipate working the project, that was a large outflow of capital for us. This is a overall $450 million project for us. And on the scale of Rush University Medical Center, it is our second largest capital project in our history. We have significant dollars moving on a monthly basis, and we had to manage that. So we started to create scenarios, and then we actually, because we were managing up in our organization to folks who, to some of them have construction and big project experience and some of them don't, we really kind of created descriptive terms of them. So we had, scenarios that were a full and immediate stop. We had scenarios that were a controlled stop, which essentially said, we're not going to stop immediately. We're going to progress to a logical pause point and then stop the project. And then we had this concept that was a controlled pause, in which we paused some elements of the process and maintained some elements of the process. That was sort of a balance point between continuing to advance the project, but also significantly slowing some of our cash flows as we work through here. And that controlled pause was eventually set with parameters. It was essentially set with parameters on duration that we would allow slowing of the project, and a primary parameter of setting a goal of the amount of dollars that we want to defer out of a fiscal year from a cash flow perspective. We actually set a target of deferring $80 million out of the current fiscal year that we're in right now. That was sort of a core parameter for that controlled pause.
Yeah, I'd say at the same time, we were actually going out for debt. So this was an interesting time for this to be happening. And as Tony was saying, as we went through these scenarios, we were balancing different risks. And part of that was, what are the impacts of this slowdown too? Because we could have just kept going spending money, but we would have been drawing down our available cash on hand, which would affect our financing. We are in constant contact with our CFO and Treasury about some of these issues, really looking at, so the impacts of slowing down things like labor escalation. If things were already in manufacturing, would we have to store them? What's the escalation on materials? Labor was the big one. So we were constantly balancing those as we were same time as we're going out for financing, as I said.
Okay. Thank you, guys. I think a great way to tee up this conversation. So let's move on. Next question is, early in the pandemic, what were your major concerns and precautions enacted relative to the Rubschlager building?
I think if we sort of break out phases and we talk about early for us, Adam, and early again, as I said, for us is really like February, March, April were early days for us ahead of the summer of last year. The primary concern, first off, was about people. And are we able to continue this work in a way that kept people safe? And that was a mix of things. It was inclusive of the job site, but it wasn't solely inclusive of the job site. It included our project management office and the folks that were coming to the site. It included conversations about, was it safe for people to come down to the site? And how might we do things to allow it to be safe for people to come down to the site? And to have conversations with folks that were on all sorts of different levels, because people entered this conversation with differing levels of knowledge. Some people were clinical backgrounds coming into the conversation. Some of them had backgrounds where they've extensively been around healthcare. Some of them were people who have very little healthcare experience and coming to a construction site and doing work. So I think a piece of it for us was very early on having really good conversations with small groups and with people together, talking about what we were learning about the virus and the pandemic, what was coming from the external entities for us about what was allowable and what was not allowable, and what we were learning clinically about this that allowed us to say in a setting and create what I think was a very good framework in those early days of understanding what it is that we wanted to do together, but also creating a framework of how we could do that work and do it together. So, we had lots of discussions internally about what was the right amount of capacity that spaces could handle from a people perspective, what was happening on the campus to maximize the safety on the campus for people, and how we were all actually accountable to each other to try and create a safe work environment for ourselves as well, to talk through that. So I would say early days were really about people. And Ray, maybe you want to comment a little bit, because they were kind of people, and supply chain was a big one that came up in early days for us as well, right?
Yeah, looking at the construction side, you're absolutely right. It was people first. As all of you know, when the pandemic started, I think we benefited from being at a major academic medical center. So we had the best thinking at the time, and we were able to share that with the construction crew. So if you can imagine a group of people that are used to working close together, like we were pouring concrete on metal deck. So if you've ever seen a concrete crew work together, they're all shoulder to shoulder, working together. But we had to figure out, well, how are you going to do that with a mask or social distancing? So we were working through a lot of things with the labor force, who was very concerned at the time. There was people that were weighing, should I go to work, or am I risking my health or my life by going, to work? So I think that was the biggest thing that we had to overcome at that time. And as Tony said, it was really educating everyone to what the latest thinking was.
And I think in those early days, right, alignment becomes a really major issue, sort of alignment. It became really important that across the various entities that were collaborating to do this, Rush and Rush employees, Jacobs Engineering and Jacobs employees, Power Construction, Ujama Construction, the chief subs that were working in there, that we needed to have alignment across leadership of all those organizations and consensus that said, okay, what's the talk we're talking about? What are best practices in this, and how can we safely and effectively continue the work that we're doing together? Because, it was very clear that what we didn't need was sort of divisions or separation in the conversations that we were having. What we were saying we thought was allowable, what wasn't on there. So it leaned heavily on team dynamic in there, because we had to have lots of conversations together, putting our heads together on this to really sort of walk through and create a plan.
Yeah, that's great. Sounds like great teamwork by all parties involved. Okay, next question. As the pandemic progressed through summer and into fall, what actions or concerns did you consider with the ongoing design and construction of cancer and neurosciences centers that will ultimately treat a vulnerable patient population?
Yeah, I think on this one, Adam, so I think the question is right. You framed it as the summertime for us. The summertime is the time frame in which we engage in thinking, okay, do we need to alter our design at all for this? It was a point in time where we felt we were a couple months into this process. We felt we had learned a lot in terms of how to do processes. And as an organization, we had learned a lot about how to create the opportunity for patients to come to this campus in a safe fashion, how to ensure that our employees were coming to the campus in a safe fashion on here. Had a lot of dialogue with our infection control team, with whom we worked very closely for this project, but also historically. We had also had a lot of learned input from our current built environment. So some people who are on this call may be familiar with our tower project. That was a hospital facility that Rush delivered with the first patient in January of 2012. And Ray and I were both part of that project that delivered that tower hospital. One of the things that we did in that tower hospital was actually we did prospective planning for bioterrorism and/or pandemic scenarios in that building. And one of the major things that we did with that was we created a relationship between our air handling in the building and the building automated controls to actually allow us to manipulate air handling in the building in an on-demand sort of fashion. And we actually leaned heavily on that functionality in the early days. So we took a section of our emergency room from day-to-day normal air handling to an entirely negative pressure environment in that setting, in a surge negative airflow model. We took sections of our acute care hospital and actually transitioned it from normal air balance for inpatient operations to negative airflow surge on there. So we were able to dramatically expand our negative airflow room capacity. And if you remember those early days, there were lots of questions about what kind of environment those patients should be cared for when they were in the hospital. So that was also part of our learned context when we were hitting the summer and talking about things that we would do in there. And so we actually created an organized structure and started looking with our infection control partners at different approaches. And some of them were things like how we would modify the physical environment. As you could guess, paints were a part of that. Elevator controls were a part of that. There were a whole variety of things that were in that conversation. Another was, importantly, how we did air handling in the building and have engaged in conversations about air ionization and a variety of other things. And a third was about whether we actually also wanted to create a sort of surge capacity in an ambulatory building and how that concept might play in there. And we actually came down on the side of that we did want to do some limited negative airflow surge capability in the building, not to the scale that we did in the inpatient hospital because we didn't think it was quite as applicable to the outpatient setting, but we created a couple key areas where we did create some ability to do some surge negative airflow manipulation for us if we needed to. So we walked through a handful of things and really leaned on our expertise of our facilities folks in our infection control to walk through different options. And Ray, you were engaged, and maybe you even want to talk through like how we were thinking about some of those elements in there.
Yeah, because we were also considering what was happening in our outpatient environment. So you can picture our new center is going to have a large infusion area for cancer patients. So we were shut down. So what are you doing with cancer patients that are coming in for chemo? So we were thinking about things like this, people that need to keep getting treated. So how would it affect this new building and what we can do? So Tony said, yeah, we were looking at, we did change some of those areas to be able to go negative should this happen again, so that we can keep treating folks should a pandemic happen again. But as Tony said, all the other things we were looking at, we're being very measured too. There was a tendency to overreact and to start spending money on systems that weren't proven yet. So we did a very thorough deep dive with our infection control folks on a lot of these systems, the cold plasma system, ionization systems, and even the things, as Tony said, we were looking at foot controls for elevators and things like that. So we were being very careful to be measured and very looking very closely at all these options. So we ended up with only doing a few of these things and actually upping some of the filtration. But we ended up not going too far in one direction. And again, having those experts at our fingertips was very valuable to us.
Yeah, the call for us as we're looking at those things is can we identify things that we think will reduce clinical infections in patient populations, right? And trying to identify data that drives those conversations and those answers in there. And we found things that we thought were open questions and things where we said, we didn't think the data was compelling and we weren't convinced that it could affect clinically our environment for us. So we have created in this, like our strategy sitting here right now is that we have a potential ionization strategy that we have not implemented yet, but we have a strategy that allows us to implement it later on in the project if we choose to do so. And we're trying to keep those conversations live with people who are putting together evidence that connects to that, which will, of course, accelerate right now in this given time. Some of the things that are physical environment elements, we just didn't think we saw evidence that said, boy, this is actually going to change clinical outcomes in our patient population or clinical safety in our employee population. So we haven't gone down the path of antimicrobial paints. We haven't gone down the path of significant usage of copper. We haven't gone down the path of changing our elevator controls to foot elevator controls and so forth on there. We're kind of always open to those conversations, but for us, it's got to be a data-driven sort of conversation that compels us, that says it's going to change clinical outcomes in either patients or in our staff.
Right, but we also at the same time, all the things that we were actively doing, especially on my side and on the entire campus, of social distancing, removing half the chairs out of our waiting rooms. And we're trying to look in our crystal ball and say, what's going to happen 2 years from now when we open this building? How much of that should we have? We can't necessarily take some of the clinical areas that we had and just spread everyone apart because we wouldn't be able to get the staffing levels we needed. So we're also weighing a lot of that, but also I think looking at, should it happen again, how can we put some of these measures in place that we're doing now, temperature taking, lining up, handing out masks. So we're going to incorporate a lot of those things that we've learned in what we're doing now, being able to have a camera taking people's temperatures, so you're not having a big queue at the door, when we open the doors. So we're learning a lot from our ongoing operations right now.
And Adam, our designed environment in this building, right, is very much a ambulatory shared space environment with central team spaces and rooms arrayed around those team spaces and so forth in there. That's very challenging from the perspective of this pandemic, right? Because we are purposely aggregating people and teams in spaces where they sort of coordinate and work together. So it's an interesting topic for us that we are working our way through as we go through this, working to project not just the timeline of the pandemic, but really more so the post-pandemic perspective and the mindset of people post-pandemic and what work environments will be like in a different way post-pandemic. It's very interesting. I think for a lot of us, probably both us here, but also anybody who's participating in this conversation, we're all kind of engaging in together, trying to project a little bit.
Yeah, let's stick with this for just 1 second. I want to add another layer of context here, because I would imagine a lot of the people attending today's sessions may be thinking, what phase of the project are you guys in now? What phase were you in when the pandemic hit? All of which is very important, because I think the timing of it, there was a little bit of a luxury here that we were still early enough in the construction phase. Ray, you did touch on things that were being looked at of retrofitting, and I would imagine a lot of the people are in these different phases right now of either they're in the design phase and still trying to figure these things out, very late in construction, like what's responsible enough to be able to make these changes. So maybe just speak to that, either one of you, from a contextual perspective of this project, which then I think will help segue into the final two questions, and having a good grasp of that and answering probably some questions that are out there right now.
Yeah, I had one thought on that as you're asking that question is, I don't think we explained what the controlled pause actually ended up, what the final solution was. It was putting off the start of the fit out. And that's how we were able to reduce the cash flow in FY21. Yeah. So if you're putting off the start of the fit out, for us, that also gave us the opportunity to start looking at what would we physically change, in a post-pandemic world. What does that look like, and what should we be doing? So that actually gave us that opportunity.
That's a really good point, Ray. And Adam, to your point of where we are, right? We were partial on our steel erection for the building when the pandemic was first starting up for us, right? And we were really completing that steel structure. And even when we created some stuff that were like our controlled stop, right? A controlled stop scenario was finishing the steel, putting the concretes on deck to give that steel the load that it wanted to have, and then pausing, right? Mm-hmm. In there. But steel was being erected near completion, and we were just sort of getting ready to start putting concrete on those decks. And as Ray said, the real thing that we slowed down was that interior fit out.
Yeah. All right, very good. I'm sure that answers a lot of questions to some folks that are listening and saying, well, we wish we had this experience at that time, because it did give us the chance to put some real good due diligence into the things that you both have mentioned. Okay, moving on. From your perspective, what was the biggest obstacle you faced and ultimately overcame as you look back over the past year working on a mega project during these trying times? And explain in detail, please.
Yeah, I think that the biggest obstacle that we faced, without a doubt, was the uncertainty of the situation, right? I mean, this was, it's so overused, right? But these were just like, this is a scenario that none of us had been in before. And trying to project it and predict it, and how much penetration this virus is going to have in our environment. Was it going to be something more like SARS, where it really ended up being less of a topic than we feared it was going to be? Was it not? And was it going to be a full-blown pandemic? Sort of managing through that uncertainty was a challenge for us. And I think for our organization, it created a lot of uncertainty. When we sat with our CFO and said, what do we need to do with this project? Our CFO was grappling with the same uncertainty that we were, right? As she looked at it and sort of walked through this. So I think one was the amount of uncertainty that we were dealing with in there. The other was just like there was cash flow as an issue on here. There was change in healthcare as everybody started trying to think about what post-pandemic is going to be like. There were also optics on this, right? So Rush went through a tough spring. Like, spring was really hard for us as an organization on this, and we did things to scale back employees' benefits while we were going through that as we worked through it. And the organization did it in a really thoughtful way and really did a lot of communication about the what and the why. But at the same time, we had a big construction project that everybody knew that we were spending a lot of money on that was still, by anybody's eyes who was just looking at there, was continuing as it normally would have, right? And our people didn't see actually that there were things that weren't happening yet on the site because of the pause. They were just seeing that there was stuff happening on the site. And so even like optics of what we were doing in the context of what was going on with our employees and just the pretty overwhelming amount of stress that was in the clinical environment at that time was a pretty challenging setting for us. And so sort of navigating through was like sort of navigating an aircraft carrier through a little strait as we were going through here. And we didn't want to be either too conservative or too cavalier as we were working through this. Those are at least initial thoughts for me. Ray, what would you add to that?
Yeah, I'd say one of the biggest obstacles, I think, too, was just the fear that I think was on everyone's mind when it first started, and across the whole medical center, and like I said, so Tony and I at the same time, you mentioned some of the other things that were going on, you talked about different methods. We were rolling out, like, significantly increasing our telemedicine program. Tony was heavily involved in that. I was heavily involved with the capital projects team, actually turning up new ICUs. We were taking prep recovery areas and turning them into ICUs over a weekend so that we can accommodate more patients. So that stress and fear of everything else we were going through, I think, was one of the big things. And there was early on, there was a lot of misinformation out there. And I personally would forget that a lot of people aren't as well informed as our team was. So that was something that we had to constantly think about when we talked to the contractors, talked to the laborers. We went out there personally. We brought Tony out and Patty out and talked to groups of foremen, socially distanced. But we educated them on what the latest thinking is on it and what they should be concerned about. And why we were taking such precautions on the site. We are willing to slow this project down. Actually, if they were worried about their safety, if they said, "Look, we have to have so many people in such a space. We are very uncomfortable." We had that discussion, and so we allowed them measures to either slow it down a little bit so they could spread out. So I think overcoming a lot of those fears and being very open with information was really important at the time.
That's going to tie even Adam into the last question about lessons learned, right? The good information calmly shared from a trusted source was invaluable for us working through this, right? Like Ray alluded to, like sitting down in the trailers with some of those folks there and talking through it, not just the leadership, but all the boots on the ground folks, and saying, do you have any questions about what you're talking about? Ask your questions. Let's get them out. Let's talk through them together. Was pretty invaluable for us.
Very much, very much. So I just want to remind all of the participants, if you could, and if you do have questions, please try to get those in. I haven't seen any yet. We are moving into our last question, and we're about right on time, but maybe it's a multi-parted one, and maybe we can do a little quick fire with you, Tony and Ray. So the question is, through your collective lessons learned, could you share with the audience what you would do differently, never do again, and definitely do again if confronted with similar challenges during a high-profile project as the Rubschlager building? So maybe we can do, each of you would do differently, never do again, definitely do again.
For us, when we talked a little bit about this, I think early on, getting as much clarity about what the puzzle is that we're trying to solve helps us be better puzzle solvers, right? We spent a lot of time in the beginning in the context of the uncertainty that was the environment, figuring out all sorts of different solutions. I alluded to at the very beginning, we had all sorts of scenarios. The scenario that we ended up picking that was controlled pause was also scenario K in a list of a whole bunch of scenarios that we developed in there, right? And the more we could prospectively say what the answer needs to be, the more we could have really more efficiently honed in on what we thought the right answer or optional answers were in there. So that's the first one that comes to mind for me on this. Ray, your turn.
Yeah, I think I'd agree on that one. I think having maybe a little closer conversation with the finance group, because we were, as Tony said, we ended up with scenario K, because we weren't clearly defined. What is it? What is the solve? It ended up being, please take $80 million out of FY21. When we got that answer, we said, oop, scenario K, let's get going. So yeah, I did totally agree with that.
I think another lesson learned, Adam, that we put on the list is we haven't had a fully cost-loaded schedule for the project, right? In terms of sort of state of the art on that topic, it would have been a lot of help for us in this process if we really could have more elegantly sort of manipulated scenarios and looked at cost impact associated with those scenarios.
Yeah, that's a good one. Great tool.
Yeah. And I think, Adam, you're the moderator, but you'd probably want to chime in on that one. That has caused some issues, and not to put that part of our team down, but it's actually reared its head in multiple areas and being problematic. So, they had their explanations. You had a couple of guys that have been in, they absolutely know how to schedule, but not having it agreed upon and have that fully cost loaded. I'd also like to have it resource loaded right from the start. It would have been a lot easier to move through some of our scenarios.
That's good takeaway. And really what that goes back to is early on expectations and early on setting those requirements in the contract. So I think that we probably have some nodding of the heads of the facilities people that are on the call right now, of either experiencing that, but then also knowing that you have to set those expectations and they have to be contractual requirements. So good one. So maybe that was the never do again in terms of that being a tool, and definitely do again to maybe round it out, guys.
I think the definitely do it again is that, to me, that topic that we hit there. I think we did a good job, especially since we said our first thing on our risk register was our people, about gathering the best knowledge there was about this topic, about the virus and the pandemic and how to actually function in a safe fashion, organizing that information and shared that information in a thoughtful, calm, measured sort of fashion. I think it helped us immeasurably as we went through that. So it was always that sort of leadership piece of take a deep breath, understand your situation, assess the situation, and then sort of start taking your steps through it. Because I think we had a whole bunch of people hearing everything, all sorts of different things in their environment that we were able to get together in a good consensus about how we could do our work. And it was a major issue for us.
Right. Yeah, because the amount of misinformation that was out there. But I would add, I think we started this project with the big room. So we have our project management team, Tony, I, and Patty, the rush management. We had the architects and engineers all in our office, and the amount of communication and trust and camaraderie that we built before this hit was really important, I think, for that level of trust and communication and just open dialogue. So we did it for different reasons, but when this hit, I think the amount of communication and trust that we had built really helped us through this.
It's a really good point, Ray, and I'll give the nod to Mike Doyle, who helped in preparing this package. As he kind of coined the 3 T's at the very, very beginning of this project, of team, trust, and transparency. And those are the things that I think you guys hit as a theme throughout, is just good communications, problem solving, being pragmatic, getting all the input, as you referenced, Tony, from whomever that is, whether it's the clinical side, the built environment, the builder side. There was lots and lots of great communication. And sometimes we tested those 3 T's, but at the end, when we maintained them, it's what really helped in getting a lot of this, getting us beyond this. So really, really good, guys. I just taking a look at the comment section. No questions yet. That does round out the presentation, everybody that's on. So if there are any questions, we'll wait here a second. for the flood door to open with all the questions. Currently, no questions yet. While we do that, Tony or Ray, kind of rounding that out, if there's any last thoughts or takeaways, that you've kind of thought on the last few minutes.
I think it's the topic of what does healthcare look like post-pandemic is going to be a fascinating topic as we work through, and how you create these built environments within which people work in ways that sort of set them up for success. And I think that's going to be an ongoing scope of work for us. And I think it's going to be imperative that communities like this one that's engaged in this today really share and talk a lot together through, because I think it'll be easy to overreact on one hand. And I think on the other hand, it's going to be easy to not be sensitive enough to the fact that people are going to have some traumatic backlash from just what we've all been going through together over the past year. So I think it's going to take a lot of discussion on figuring out what the right kind of middle ground is that says, no, we don't have to put everybody more than 6 feet apart from each other and in their own separate bubbles. And at the same time, it's not just throw everybody back together and you go back to normal, because that's going to be hard for people to do.
Yeah. Right, we're spending a lot of time on that with the capital projects team. Is a lot of people have been working from home, and we're taking a much closer look at what's the work environment now. My wife is in e-commerce, so their team didn't skip a beat because they were used to working remotely, but that's not what's been our experience in healthcare. So understanding what the balance is from work from home. A lot of people in healthcare do it because of the teaming environment. So we're looking at those teaming environments and what do they look like? Is it hoteling space? Is it dedicated space? And that's what we're looking at also for the new building, officing, same types of things where we were getting more and more collaborative actually with our new building, with the module concept and teaming areas for the physicians. And now the word is, social distancing and stay apart. So we're going through a lot of that now, as I'm sure anyone else out there that's listening. So so I agree with Tony on that one.
Okay. All right, guys. Well, it looks like no questions have come in. I'm going to give a 5-10 second here chance for anyone as we kind of wrap this out, but appreciate very much your time. I think it was a great presentation. I think as the attendees know, there's a breakout session after this, a networking type of environment. I think Tony and Ray, both at the bottom of the hour, do have to go. I will join that session if there's any questions I can field or bring back to this team. I think Rush is, again, Rush University Medical Center, and just as an institution across the board, but also with Tony, Ray, and Patty personally, always looking to collaborate and help. So if there are things that we can open up dialogue and take from here, I know that they'd be willing to do that. So, all right, looks like no questions have come in, guys. So got off lucky. Thank you for your time.
Adam, thank you for hosting us. Appreciate it.
You're welcome.
Thank you.